So, greetings everyone. Thank you for coming out tonight to listen to this talk. It's just purely educational, as I've already said. If anyone has any questions or wants to stop me for anything at any point for clarification, please let me know. What we are going to talk about today is hypermobility, its association with pain. Is it possibly a cause of your pain? And what exactly is hypermobility? Before we get there, we'll start with a little bit of what is hypermobility, how does it manifest, how do you know if you have it, how to treat it. We'll kind of hit on a lot of different things. If we want to go deeper, you just let me know. So my name is Jeff Crayer. I go by Dr. Jeff. It's a lot easier in the last name. It does not really matter. The question is, how did I come to be here? Who am I? Why hypermobility? Why functional medicine? So I'm an internist and a pediatrician who has a specialty in sports medicine. I started out practicing 20 years ago doing lifestyle medicine, saying it's about diet, it's about movement, it's about stress management. That is health. I did not know about functional medicine back then. But as I started having patients become more active, I didn't know how to take care of their musculoskeletal injuries, and people were coming in with pain. I was like, I don't know what to do with you. So I came to Boston and did a fellowship in primary care sports medicine. Felt good about that, went back to my practice, came back to Boston, fell into the Boston trap that you can't be a generalist and a specialist, and went down the rabbit hole of giving up general medicine for a while. And have been working at Mass General in the Department of Pediatrics in the Department of Orthopedics doing pediatric sports medicine and orthopedics because there's so much psychology, fun play there, and I love the kids. I love my adults too, but it gave me time to find functional medicine that presented to me. So I spent the past 4 years learning more about functional medicine, saying this is my tribe, these are the people that I resonate with. It is lifestyle medicine elevated to a higher level. How do you take the complicated cases that some of standard medicine is saying, we don't have an answer for you? Come on, you have to have some answer. We have to have something to offer our patients. So that's a little bit about my background. I'm currently doing primary care with a functional medicine practice 2 days a week. I'm still doing the pediatric and adolescent sports medicine 2 days a week. And I'm doing another day of bioidentical hormones and integrative care in general. So the goal is to eventually build out WellSaid Health to come and be a source for community health in Southern Maine. Right now, yes, I'm based in Boston, and this is purely educational. I'm not licensed in Maine, so I cannot necessarily treat in Maine, but teaching and education is one of those things that I love and pass along the information. How many people have heard functional medicine or are comfortable with functional medicine? So in all of medicine, people use definitions differently. So functional medicine means a lot of different things. To me, it's essentially a form of integrative medicine, which covers a lot of things, Eastern medicine, Western medicine, put together, but getting at the root cause. There are many different definitions, many different iterations of it, but I do like Mark Hyman and the Institute of Functional Medicine's acknowledgement that one condition can lead to many imbalances. So I apologize. Many imbalances can lead to one condition. One imbalance can lead to many conditions. So this is a non-reductionist approach to medical care. Okay, instead of saying we're going to name it, we're going to blame it, and we're going to tame it with a prescription, it's looking at all the potential causes. So there's all these cliches in functional medicine. I own none of them. Okay, they're all other people's words. So I'll say that right up front. Institute of Functional Medicine is just one certifying organization within it, but I do generally, I'm just looking to see if there's a pointer here. No. The matrix is sort of the Institute of Functional Medicine's approach to this, and it's a more integrative approach rather than saying the cardiologist only deals with your heart. Well, actually what's going on with your heart affects your hormones and affects your nervous system and affects so many different things. So again, getting away from that reductionist approach to medicine and integrating how everything leads to health. At the base of your health is lifestyle medicine, sleep, stress management, nutrition, movement, and relationships. It's about connection. And the center of the health is the mind, body, spirit component of this, the mental, emotional, and cognitive, or spiritual portion of this. So it's a general approach. Now this talks about Ehlers-Danlos syndrome or hypermobility. What do you think of when you see that image? Is that normal? Can everyone do that? This is something, hypermobility is not a new condition. However, the attention it's getting is definitely much more prominent. Some people look at that and say, ow, pain. And this is a common presentation in my clinic. Yes, I deal and live in the world of pain. And sometimes it is hypermobility. A lot of time it's hypermobility. I love my internal medicine practice. But I was drawn to the kids because I wanted to fix things before it got to where I had fewer answers. And so that's why I play in the pediatric adolescent world and hypermobile world to try and say, how do we change this trajectory of hypermobility and pain? Okay. Now, what is hypermobility? What are the terms? Okay. Hypermobility syndrome is one that can be used synonymously with the second one, the nine-joint hypermobility syndrome. The newer term, you know how we like to do it, we like to change up the term so we can always sound smarter than the patient, is hypermobility spectrum disorder. We like our spectrums, we like our disorders, let's throw them all together. But hypermobility is probably a better term than Ehlers-Danlos hypermobile type. That was a wastebasket in the past. When you were hypermobile, you just got called Ehlers-Danlos syndrome hypermobile type. Okay? So I do feel it's a better approach recently in the past couple of years to try and tighten up the definitions. So the true phrase, at least so we can start studying it and getting better answers, is hypermobility spectrum disorder, and where do you fit on that is variable for everybody. So what is joint hypermobility syndrome, or what's hypermobility? Let's forget the joint hypermobility. Hypermobility goes by Beighton score, modified Beighton score. And you're going to see a picture of this, it's coming up. But there are 4 scores, and guess what? I have one. Thumb to the forearm, it's 1 or 2, score points 1 and 2. Pinky to 90 degrees, 3 and 4. Elbows, I don't have these necessarily, 10 degrees negative, there's 5 and 6. Knees, 10 degrees negative when you hold them straight out, 7 and 8. And 9 is being able to put your palms flat on the ground while keeping everything straight. Now, I think it's a silly score, because if this is something that's throughout your body, why would one side be affected and not the other side? But it doesn't matter. So if a score is 4 or more, and you have the thumb and the finger, you have hypermobility, like I do. Now, hypermobility syndrome, by definition, is hypermobility with pain in 3 or more joints over 3 or more months. So there's a lot of hypermobile patients that have hypermobility syndrome. Now, hypermobility is something that the younger kids are born with. This is just that Beighton score. But as we get older, we do lose the hypermobility. So there is a second sort of definition. Could you ever place your hands flat on the floor? Could you ever bend your thumb? As a child, did you amuse your friends by showing off your party tricks? And then dislocations of the shoulder and the kneecap. Those are the 2 most unstable joints. So have you ever been labeled double jointed? So that definition is pretty broad. Okay, there's a lot of people that would find that. So what truly is Ehlers-Danlos syndrome now? Hypermobile type. It is the Beighton score slightly higher and skin involvement, that hyperelasticity, being able to pick up the skin and hold it pretty high, okay? Or a velvety skin. Now, that is Ehlers-Danlos syndrome, hypermobile type. There are a lot of patients who carry that diagnosis that may not necessarily be diagnosed as such today. Ehlers-Danlos syndrome is a whole lot of different conditions. And this is all EDS. There are genes for all of them, but the hypermobile type, no definite gene. So why is there so much hypermobility now? Why does it seem to be going up, like autism? This is the appeal of functional medicine, the medicine of why, or getting at the root cause. It's not like we're breeding for hypermobility. At least I don't think so. Okay. There is no defined molecular or genetic basis. It is a connective tissue disorder. So again, in the semantics, hereditary connective disorder is a big, broad term. It encompasses a lot of things that are not Ehlers-Danlos syndrome, hypermobility spectrum disorder, but it is going to involve connective tissue, skin, eye, bones, internal organs, and there is a variable expression. You see one patient with hypermobility, you know one patient with hypermobility. It can be expressed in many different forms. So it is, what's interesting to me, a multi-system condition. It's not one thing, one answer. So you have to be very comprehensive in your approach to a patient with hypermobility, whether it be hypermobility spectrum disorder or hypermobile Ehlers-Danlos syndrome. It does affect the autonomic nervous system, gastrointestinal disorders, chronic pain syndromes, chronic fatigue, anxiety, pelvic floor. What is connective tissue? Where is it? I said eyes, whatever. It's throughout your body. What is it involved with? Fascia. What do medical doctors know nothing about? Fascia. What have we always just cut through to get to the organs? But connective tissue, collagen, it's throughout your body. And so everything, many systems can be affected. So some of the variable expressions, some people show it in their sex hormones, some people have variable motor control. Proprioception is one of the root causes, or kind of deep down in there. A variation in the pain modulation. The nerves run in the fascia for the most part. If you have dysfunctional fascia or extra stretch in your joints, what's going to give? Your nerves, or things that are related to pain. Adaptive coping strategies. This is something that, yes, my partner, she's a philosopher, and I like existential health. How do you live your life when you can't even trust your body? You know, it doesn't do what you want, or you don't feel like you navigate space. You feel clumsy, or you're always in pain. That's not the way we are meant to live. I do subscribe to the naturopathic dictum that the body is an amazing entity that has a great potential for self-healing. But what is keeping it from self-healing? That's always the question. So weight, diet, all these things can be affected by a hypermobile body, your physical activity, traumas, surgeries. So I had mentioned that this is part of connective tissue disorders. I'm going to try to move through this so we can get to really sort of the treatment, or how would you approach it. So I don't want to spend too much time on this, but there are other hereditary connective tissue disorders listed there. So how common is it? Why does it seem like my whole clinic is filled with hypermobile patients? Well, it depends on your definition. It depends on the time of the study, and it varies. But it seems like everyone in their cousin has hypermobility. Generalized joint hypermobility, meaning just a bite and score, that's elevated. 6 to 57% of women. Okay, 2 to 35% of men. Very common. I'm one of those. Do I have chronic pain? The answer is no. I don't, but of those, 3.3% of the women and a lower percentage of the men. I spend my time with the younger population educating, because everybody hears the vocal minority. That vocal minority should not be told to stop talking. They should be understood and helped, but not everybody has chronic pain with hypermobility. And so that's one of my things. I want to catch them early and just say, this doesn't have to be your life, but we have to work on this because it can be. I do not want to foster or allow any more pain in this world than I can allow. So Ehlers-Danlos hypermobile type, Prevalence anywhere from 1 in 5,000 to 1 in 2,000. So you're still looking at low percentages, but of them, pain prevalence, 30% of children, more than 80% of the adults above 40 years of age. So the natural history is a progression towards pain. What are the sources? This is the fun detective work, getting at. What is it? Joint subluxations, that means kind of shifting in and out of joint. Dislocations, meaning somebody had to push it back. Instability, because you have to, because you've had subluxations or dislocations and it's unstable. A previous surgery can give you hypermobility. Muscle weakness, proprioceptive disorders, that's our fancy term for balance, or not balance, that is not the correct term. Proprioceptive is where are you in space? How do you sense yourself in space? And if that is disrupted, then you're more likely to turn your ankle or get an injury. Vertebral instability, just another joint. General pain, fatigue, headaches, GI pain, TMJ, temporomandibular joint pain, pain with periods, pains around the vulva, impaired sleep, impaired social relationships. How is this not important to tackle? Okay, so what are the causes? The loss of proprioception to me is a big thing. Disturbances of where we're at in space, that proprioception. When you get pain, it is not made up. It is not this. Central sensitization is a better term for pain amplification. So the way I explain it to the kiddos and the adults is if your ankle is sending your brain messages that it's in pain, yet you're always in pain, what would the ankle say? You're not listening to us. Let's turn up the volume. That's pain amplification. It's really not the way it's going. It's more central sensitization. But it gets the message that we have to respect pain. Pain is our body speaking to us. Let's listen to it. Let's respect it. And do everything we can to keep that down. So,
I got a couple of simple questions.
Yeah.
So is like normal? I have, muscular pain, for example, is when you use a muscle too much, it starts having pain. Stop using it, and pain usually diminishes. But is that the case here?
So, this is a problem because a lot of people want things to be reduced to one answer, and I give a lot of So, I'm not the world's expert on pain. Everybody's pain is different. But generally speaking, I don't care about muscle pain. You tear your muscles, they hurt, they heal. I'm okay with that as long as it does go away. A lot of the pain in hypermobiles are a combination of excess joint force, too much pressure on the cartilage or the bones, too much stretch of the nerves, or being in chronic pain in the central sensitization. So those would be the three main categories I put the pain into. Now,
so it's the hypermobility that's causing the pain.
The hypermobility leads to a dysfunction of one of those. Yep. And what I tell my hypermobiles, you can be a professional athlete. If you took professional athletes, a lot of them are hypermobile. But they've developed that, it's my contention, they developed that proprioception that, hey, maybe I roll with it, but I'm not going to fight it. I'm just going to roll with it, and my ankle's fine at the end. I recover quicker. I'm getting to your question. I apologize. I lost my train of thought. Pain. Can you repeat your question? I apologize.
Yeah, I was just wondering if it was a chronic pain symptom that was non-related to the hypermobility, or if it was like fascia or tendons or something that was in chronic inflamed condition that wasn't related to, when I bend it, it hurts. When I don't bend it, it doesn't hurt.
Yes. So I'm going to get to that too, because now I remember where I was going. People who are hypermobile, because you had this time element to the question earlier, they just have to work harder for muscular endurance. Muscles that go for a very long time, they are penalized in that. I don't want them to be super strong, but I want their muscles to go for a long time, because when they go into fatigue, which happens with physical activity, then there's more shifting, more forces, more stretch of the joints, more joint compression. So they have to have greater muscular endurance. And it's less the muscles as the pain generators as the nerves, and the change in the microglia, the immune cells of in the brain. So we used to think it's all about the neurons. It's really about the interface of the immune system in the brain and that sensitization. So it's more neuro. Not because, but if you cause inflammation, and that sensed as pain by the natural chemokines, so I don't want to throw too many fancy terms around, but the chemicals released with inflammation, you can be more sensitized to that. It's still a nerve pain. But yes, muscle pain can cause, a tear of your muscle can give a hypermobile patient more pain than someone who's not hypermobile.
So I guess what I'm getting at is, does a splint where you reduce hypermobility in some joints, does that reduce the pain?
I'm going to come back to that in the treatment aspect of things. Yeah. Yes. Yes. Now I'm going to come. So getting at what is the cause. I mean, we've kind of hit some of this. The abnormalities in the extracellular matrix, again, this fancy term of connective tissue disorder, fascia, connective tissue, collagens, whatever you want to call it, it's throughout the body. These collagens, fibronectin, those are abnormal. We don't have one gene that's abnormal. It's a constituent of them. And for whatever reason, they move a little bit more. Well, if the connective tissue has a little more pliability to it, then you can get more tensile or compressive forces, okay? So this is that proprioception and nerve firing. This is why the GI gets affected. The GI also has a smooth muscle layer around it and fascia, and if you can distend your intestines more, that can give people symptoms, okay? So it can go into then the organs that aren't necessarily muscle, tendon, ligaments that some people think about. Also, again, because the nerves run in that fascia or around those things that are distending, they also get a stretch abnormality to them. So, getting to what you're saying, the increased immune system activation just due to injury, stretch, excessive force, excessive movement, whatever the cause may be, does get us to inflammation, where a lot of functional medicine likes to put their attention. It is another inflammatory condition due to the underlying condition. Now, am I going to change anyone's genes? Am I going to change their fascia or their collagen or their connective tissue? Not likely. But I can work on the inflammation, and I can work on some of the things like splinting and the other things to prevent what leads to the inflammation in those afflicted with hypermobility. Okay? You can see that, yes, all the stuff that happens peripherally can lead to the fancy term for the activation of the immune cells or the microglia in the brain. So what does a natural course look like? Someone will start out, where are we at? Okay. So joint hypermobility, increased visceral compliance as part of the hypermobility. If that is allowed to lead to soft tissue injuries, microtrauma, and visceral dysfunctions, then you start getting the pain sensitization. The body says, hey, this is not a norm, we're living in pain, what are we going to do about this? Then you get your widespread pain syndrome, your hypersensitivity, and then worsening debility. Everything, the world contracts, you lose your connections, you can't trust yourself out in public to not have pain or to not fall and injure yourself. So the goal being, how do we let hypermobile patients live and not get to the maladaptive, or I don't like saying maladaptive, but the later stages. So nociceptive is the fancy term for pain that's coming from the nerves, neuropathic from how the peripheral nerves are appreciated, and dysfunctional from the central processing. Again, another little timeline, young age, joint hypermobility. Maybe they have subluxations or dislocations. Maybe it's just growing pains. They hurt. Are all growing pains hypermobility? The answer is no. But should you ignore all growing pains? The answer is no. Again, more widespread pain, neuropathic pain, and then if you're always in pain, your sleep gets disrupted. How are you going to feel like you have energy? Then you're dealing with chronic fatigue and all those things. I've kind of glossed over the fact that your autonomic nervous system gets involved in all this. That's your fight or flight, well, sympathetic and parasympathetic, that balance. If you are always in pain, the nervous system gets involved and can also give you some dysautonomia, or the fancy term everyone's talking about now is POTS, postural orthostatic tachycardia syndrome. And then there's even some overlap with mast cell activation syndrome. So it hits all sorts of things I love to talk about. So the primary treatment, early diagnosis, educate, educate, educate. I told you I love to teach. That's why I'm here. I love to teach. And I do think that our health is more responsive to the more we know. It is a chronic but manageable condition, and it needs to be around effective communication and respecting that person and their experience of this, because everyone's experience is individualized. You need to know about activity modification, pacing, self-management, and let them know that this is something you can control. I do a lot of education. What's acceptable pain? What's unacceptable pain? I don't know. I generally say pain is our body talking to us. Listen to it, respect it. But what's unacceptable pain? Unacceptable pain is progressive pain. If you do something, you have pain, and you stop, respect it, it goes away in 10, 15 minutes every time, I don't really care about it. If you have pain, you stop, you respect it, and one day it's 15 minutes, the next day you do the same thing and it takes 90 minutes for it to go away, and the next day it's 4 hours later. That's progressive pain. Something's not being respected there. Let's go back and reassess how we're processing the pain. So what does a functional medicine approach look like? At least in my world, I come back to the matrix, I talk about the personal lifestyle factors at the bottom, and trying to get at the root cause. I'm not going to change the genetics, so I want to do everything to minimize the sensation of pain, talk about the person's experience. You cannot forget that this is an interface of the mental, emotional, and spiritual, and that's the attention to the existential health issues. Sorry, that's just one of my things I love to talk about. But therapy, cognitive behavioral, physiotherapy, and what do those look like specifically, okay? Treat the comorbidities as you're having fatigue, pain, sleep gets affected. You have the fatigue, the psychological distress. This is your body. You should be able to live a full life, and this is a challenge to you live in a full life. So when we talk about sleep and relaxation, this is, unfortunately, I'm a straight shooter. I'm from the Midwest, so that's why I want to get to Maine as quickly as possible and leave Boston. It is trial and error, okay? You have to play with your cushions. You have to play with your mattresses. You have to try everything to get comfortable sleep, okay? The exercise and movement, this is where I would say if you know anyone who's hypermobile dealing with these issues, this is some of the simplest stuff to do. Compressive clothing, something that gives that proprioception back. You know, just something that's really tight. There is a reason splints work, but also just knee sleeves. So this is a study, you didn't ask for this, but in arthritics, half of knee arthritis adults have reduction in their pain with the knee sleeve. You roll the sleeve down and they don't have it. So in the people that feel better with compression, why? We put electrodes on their muscles, and with the sleeve on, they fire their muscles milliseconds sooner. You take it down, they fire it later. So we believe that compression is getting better joint or muscle firing patterns and better joint stability. Why can't we do that earlier? You know, I think the kids generally, if they're allowed to play, know their bodies even better, and I think they respond better.
So that stabilization of the joint is preventing it from moving out of alignment because the nervous system is off.
Correct.
So would
that's the hope.
We kind of desensitize, or we're actually less fire.
Preventing. I'd say more preventing than desensitizing. Yeah. So sorry.
But if you get to the point where you're having pain due to those sensations, or daughter experiences more pain with compression clothing.
Then the answer is no. Yeah, go
Not
ahead.
muscular, it's the nerve issue. So at some point, I mean, obviously it's not an exact science, right? There's lots of different variables to that.
So for those that didn't hear it, some will feel worse with compressive clothing. Then you don't do it. That is more neuropathic pain. And until you respect the neuropathic pain or that increased sensitivity of even a little pressure is worse. So this is more of a preventative before you get there. Like I have no relationship to any compressive clothes, but they've got to be loving me, because if someone's hypermobile, I'm like, think about this. Think about the compressive clothing. Yes, when you are really suffering and compression hurts you, your nerves, I would say, are more the source of the pain.
So it makes a lot of sense, because our kids are hypermobile, and they play ice hockey. And the thing about the equipment, it's very form-fitting. Everything. She has pads, the leg pads, the knees, everything. So that's why it worked for them.
Correct. Those that didn't go on to have pain, is that what you're saying? Or?
Well, I mean, all the way growing up, it wasn't like they had pain until other extenuating circumstances. But you know, they were able to play. They balanced with that sense of
proprioception. Yeah. And you know, that's so. Do I have studies to back up anything I'm saying? No, this is just experience and watching and being very inquisitive and asking. And unfortunately, a lot of medicine is practiced at N of 1. And yes, I have my experience. I played a lot of sports. I'm very hypermobile. And I didn't develop pain. And I always say, why? Well, probably because I played a lot and sensed different positions. So when I say proprioception, how do you do that? Changing positions, maybe even wrestling with dad or mom. Maybe that should come back. You know, when you get twisted and turned around and have to understand, where am I at in space? I like that. Playful, not hurting, but playful wrestling, wrestling with others. I think there's something to that. I think also, because I deal with concussions, as people aren't able to predict the hit, there's more force of the neck, and they're not ready for it, and there's more concussion. So proprioception, to me, plays a big role in concussion too. Textured shoe inserts, if they can't sense the ground, the texture is actually something they feel to help give them that feedback. TENS unit, for those that don't know, it's just a electrical stimulating unit on the skin to get the muscles to respond. That treats the gated theory, so maybe you can desensitize the nerve by stimulating a lot. And work in home ergonomics, you know, being respectful of positioning, sitting, laying when you need to lay. So still in the exercise movement, yes, I love my physical therapists. I love my chiropractors that really work on these things. Getting trunk and core stabilization, re-educating them. Sometimes they have no clue where they're in space. I'm like, sit up straight. And they're like, what are you talking about? And you know, you have to give some feedback. They don't just feel it. Joint stabilization, strengthening, joint awareness, that biofeedback maybe of compression if it's not setting off neuropathic pain. Joint mobilization. Guess what? If something hurts, the more you move it, all the muscles are going to tighten up to try and stop that movement. So some of that tightness is protective. You don't want to just free that up without the strengthening. So stretching isn't the answer. But if they are hypermobiles to the point that they've tightened up, what happens over time? We lose that hypermobility. It's maybe the body trying to protect itself, but it's a much more tense body. So some release techniques in the right hands, and then manual work for those muscles that are overworking, and acupuncture, absolutely great for pain. Some of the modalities that you can get through physical therapy and some chiropractors, electric stimulation, ultrasound lasers, I call those things my Bandaids. They temporarily reduce the pain so that you can strengthen. If you have pain, muscles get inhibited by the spinal cord. If muscles are inhibited, then you have more force on the joint, generally speaking. If you have more force on the joint, you have more pain. More pain, more muscle inhibition. We've got a problem here. So sometimes we just need to break the pain so that the strength can shine through. Kinesiotaping, splinting, bracing, aquatic therapy, there's just a whole list of things, and it's a menu. Find what works for you. The aqua therapy, because of the water around the body, helps with the proprioception, I believe. So, nutrition, yes. We talked about inflammation. Yes, anti-inflammatory food stuff. Going clean and organic as you can. Omega-3s for their inflammatory benefit. If those of you looking for specifics, I won't give great medical advice or deep, but really more like 3 to 5 grams in a day. A pretty decent dose can be very anti-inflammatory. Curcumin on a regular basis. This is the hot topic. Even within functional medicine, it's not about pushing the blood level up. That's a misconception, okay? That's the pharmaceutical model, okay? Let's push up the concentration in the blood. Guess what? Curcumin works on your gut, the microbiome, okay? So it's not about a more bioavailable form of curcumin, it's about what's working. And unless you're eating a true native Indian diet, you're not going to be getting the amount of curcumin without supplements. Functional medicine does not equal drugs replaced with supplements, at least not in my book. Some practice that way, but there is a place for omega-3s and curcumin, especially as anti-inflammatories.
Say again about what you're eating
Like a native Indian, not Native American, Indian diet, the amount of curcumin you're getting is minor.
Yeah, so any kind of supplement is just not going to any kind of
frequent, yeah. It should be pretty frequent. You should be doing it 2 or 3 times a day.
Yeah. Okay.
Yeah. If you're really wanting to use curcumin for its full benefit.
How many grams is
So this is where I'm a little caught between the identical model, but it's about 1 to 1.5 milligrams on 95% curcuminoids is what has been most recently reported as beneficial in the studies, but I'm also starting to question that now.
Yeah, so for curcumin, based on what I know, you're going to have just the curcumin in the more natural form. They often put it with black pepper for absorption.
Mm-hmm. Yep.
They often will use the water soluble. Like some suggest there's like a sweet spot of the dosage, and I think it varies per person.
Yeah. And I imagine you guys carry orthomolecular. They're a company, a supplement company I do like, and they're going back. They're really forcing the science talk. And their product has nothing to do with bioavailability. It's the whole curcumin. It's the root. It's everything together rather than just trying to isolate the chemical. It's trying to counter that reductionist approach. And then I think you have a little handout there about eating the rainbow. This is just a simple thing as an anti-inflammatory. Think about your diet. Think about getting all the different colors. On that handout is the benefit, the phytonutrients in all of this. Now I don't know how up to date everyone is. There are some people purporting a carnivore diet and that phytonutrients are a plant's defense, like lectins, and that maybe we shouldn't be taking them, but they stress our cells to a certain amount so that we adapt. How do we get bigger muscles? We stress them and they adapt. So stress is not a bad thing either. Pain is not a bad thing. They are things to learn and learn from. So I still buy into phytonutrients and eating the rainbow, not just only greens. I love greens, but mix in some reds and some purples and everything like that, and definitely more veggies than fruit, but we should be able to eat fruit. Yes, sugar is a bad thing, but we should be able to eat fruit, okay? So knowing what the dirty dozen is, clean 15, I don't want to spend too much time on this. I want to kind of get through this so you guys can ask questions. There's a little too many slides here. So I'm going to start moving a little bit quicker. If anyone wants me to stop, please stop me. So the nutrition, eating the rainbow. Stress, relationships, thinking about cognitive behavioral, recognizing that, you know, I'm not living this experience, but you can live in fear of pain. I mean, that's a very natural experience. Fear of moving around. I mean, some people get so debilitated, they can't go out in public. And I'm telling you, I need you to strengthen. If you lay around at home, you're only going to get weaker. I can't just say move. You know, I have to give some help in that arena. Splints and recognizing where can we rest, where can we get our work in, and move forward. So that fear avoidance and social connection. You know, those that are really affected by pain and fatigue and sleep interference, they're losing their connections. People can't go out with them because they don't know if they're going to be able to get to where they want to get to. So If you're going to talk about drugs, I'm not a big drug proponent, but these are a couple things to think about. Tylenol over NSAIDs due to the GI issues and the leaky gut with ibuprofen, Advil, naproxen, Aleve, all those things. Tramadol over opiates. Opiates leading to constipation, pain sensitization, and mast cell activation syndrome exacerbations. Caution with the steroids, more due to the long-term effects, blood pressure, bone health. Some will do this just to stimulate the adrenals when there's chronic fatigue. It's a very, very poor Band-Aid. And caution with antidepressants and anticonvulsants. I said we have to address someone's health, mental health, but it can increase the dysautonomia or the orthostasis in some patients.
Can I ask a question on the specific antidepressants that are linked to that, or just all types?
It's a good question. I can't say that I would differentiate amongst them. When I say most of them are that are going to affect the SSRIs, but SNRIs to the serotonin norepies, I wouldn't say that they would be excused from it. But I wish I had a better answer. I don't.
Any convulsants, caution for any convulsants, if someone's taking any convulsants, they understand pretty good reason.
So you're saying on that, yeah, if they have anticonvulsants. Some people are using anticonvulsants as pain relievers. So if they're using them for that's a great point, and thank you for that. If they're using them for seizures or convulsions, they should be on them. If they're using them as a pain reliever, that I'm a little less certain of. So when we talk about supplements, if you're going to look at it, maximize the immune function. Vitamin D really isn't a vitamin, it's a hormone. It affects so many systems within the body. So I'm not a vitamin D zealot where everyone should be 80 and above, but I do believe it should be higher than where most people are, more in the 50 to 80 range. The omega-3s, EPA and DHEA for the immune function, the central aspects of it, the DHEA working on the brain a little bit more. The brain is 80% fat lining the nerves, okay? So that's, if someone says, why do DHA and EPA help the brain? Because the myelin wrapping up your nerves is fats. Berberine is another great immunomodulator working at the cellular level. To consider that dose is around 1 gram daily, whether you do it split dose or all in one is a little uncertain as to one being better. If sleep is a problem, addressing it. And that doesn't mean jump to the melatonin, it means deal with all the other potential things that you could do. And if you need supplement melatonin, but then passion flower, L-theanine, there are a lot of different options there. Respect muscle weakness. If I'm saying that we're trying to bring down pain, and muscles help decrease the forces on the joints and or the stretch of the nerves, maybe there is some of the deficiencies of nutrients for the muscle strength, and that being carnitine and coenzyme Q10. Future direction, maybe oxygen, maybe ozone. That's a little more on the edge. But treatment of mitochondrial dysfunction, this is coming a little bit more from the chronic fatigue world. Those with chronic pain and hypermobility are showing some defects of oxidative phosphorylation, how we generate our ATP or our energy currency, and that is the electron transport change, the ATP production. And then low-dose naltrexone. Has anyone heard about this? Yeah.
And I get it filled here.
Yeah. And why does it work? Do you know?
So right there, yeah.
Yeah. Suppressing the activation of this central sensitization or the microglia. That is the proposed mechanism. This is a low dose. It does not have any mood altering effect at all. It's very low dose and it works wonderfly in autoimmune conditions and maybe chronic pain. Yes?
We did talk at all on treatment, about technologies that sort of cover those little ones in?
The treatment of mitochondrial dysfunction, so I wasn't, but I was going to respond to any questions. Treatment of mitochondrial dysfunction can be supplements and replacement of substrates, but then red light therapy at a certain wavelength will stimulate mitochondrial dysfunction. If it doesn't have the substrates, then that red light I'm not sure is as effective. So you always have to make sure that substrates, coenzyme Q10 and or carnitine to filter fat, or not filter, shuttle fat into the mitochondria.
Are you familiar with the vector?
What is it?
Vector machine that basically is electrical stimulation with more oxygen to the nerves and so on?
No, I'm not. But can you tell me more?
No, pretty much a novice at it.
Okay.
But it's, well, I think when this progresses to more like CRPS-ish, right, then you're looking at a lot of different type of treatment options.
Yes, sure.
And we're just exploring some of those things, and there's FDA now approved, or ADA approved, I guess.
It's basically a machine, it's kind of like a TENS unit, but much lower frequency.
Okay.
And then it's working on improving the circulation.
Okay.
Measured by
Beamer? Like a Beamer? Have you heard of Beamer?
I've heard the name. I don't know much more than
It
that.
like activates the mitochondria, kind of like a low-level laser works. More opens up the microcircuitry.
Yeah.
That's what it does.
And so there was also a term for those that didn't know, CRPS, chronic regional pain syndrome. Pain amplification is a form of CRPS is a form of a pain amplification syndrome. Pain amplification is that central sensitization. CRPS is a pain amplification syndrome where you just stroke the skin and there's pain. Why should that hurt? But there's that amplified signal with the dysautonomia, that the common symptoms are changes of color of the skin and localized sweating. Those are the two big ones that stand out. And so I find much more pain amplification than true CRPS, but there are those affected with CRPS. It doesn't matter, they're both pain amplification syndromes. For whatever reason, I used to see a lot of CRPS, but now POTS is taken over, and I don't know why all of a sudden dysautonomia is expressing itself differently. There are a lot of why questions I struggle with that I don't know, and so if anyone has these answers, I'm very open to them.
That's a real challenge. How do you diagnose it? Right? How do you, that's the challenge. How do you get an answer to understand what it actually is?
Yeah.
Right?
There's some CRPS or pain.
Whatever it's called. So our daughter had 2 hip surgeries. Dale's on both hips that triggered, I think, a stretching of the nerves that's now become this potential CRPS type.
Yeah.
Right?
Yeah.
So, and if you don't deal with it, it goes way beyond just uncomfortable. It's a
Correct.
chronic, right?
Yeah.
But trying to get an answer, trying to find a place that really do some thorough deep dive to say, hey, what is it? And do about it.
it's a whole specialty thing.
Correct.
And there's lots of-
And different definitions. Yeah.
And there's lots of things doctors will want to do that will actually exacerbate the problem, not make it better, right? And so it's just a challenge.
Yeah. I don't have the answer, but I'll just say it real quickly. Some of the research is getting really cool about skin galvanization, or testing the skin reactivity to current and measuring those potentials as, they're using it also to get those that are saying they're in pain and aren't. So there's some interesting stuff maybe around the corner.